What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
What's up, everybody? This is Dr. Zach Baker on the Strength and Knowledge Podcast, and I have got with me today Dr. Bami Adu, who is one of our two sports residents that we have in our cohort this year. And Bami treats clinically out of our Germantown location and then meets every Thursday with myself and our other resident, Christian Huckfeld, at our Mount Airy location. And that's where we go through more of our classroom educational time. It's kind of a hybrid of some lecture and some lab experiences. But one of the competencies that they have to do as part of the residency is doing a monthly journal club. So the purpose of the journal club is they find a journal article that is relevant to the topic that we're studying that month. This month, for example, is the knee, which is my favorite thing to study and favorite thing to treat. So I'm excited that we were able to do this one. I'm very excited about the topic that Bami selected for us because it has to do with gait mechanics and ACL injuries. So Bami, welcome onto the show today. Do you mind telling everybody just a little bit about the article that you selected and really why you selected it?
Sure. So I chose running biomechanics in individuals with ACL reconstruction. So I chose this article because it's pretty well known that sagittal plane knee mechanics are the most altered variables during running. This article does a really good job at understanding those alterations and how those alterations may affect an individual long term. So the study really looks at the differences in gait and running biomechanics up to 5 years post ACL reconstruction, which I thought was pretty cool.
That is pretty interesting. You don't see a lot of studies, or you don't see as many studies, I guess I should say, that follow it for that long of a time period. And I think oftentimes with any post-surgical condition, we get locked in the moment of, what those first few months after surgery looks like. We're very in tune throughout the rehab process. Then they get discharged, and we just kind of assume everything is back to normal and stays normal beyond that. So this article will be interesting because I think there are a lot of different ways that you can go in one, assessing gait mechanics, but then really coming down to the conclusion of what's influencing these gait mechanics. What are the different properties and principles that we have at play that can alter somebody's ability to move well or demonstrate the ability to move well? So getting into this, Bami, do you mind talk to us a little bit about just how the study was set up? What type of patient population were they looking at for this study?
Yeah, so this was a systematic review, so they pulled in 25 articles together. Of those 25 articles, they had about 622 participants who met their inclusion criteria. So their inclusion criteria was your standard PICO format, so population was a male or female who had undergone ACL reconstruction with any type of graft after isolated ACL injury or in addition to meniscus and or collateral ligament injury. The intervention they used in all these studies was assessment of running. For comparison, they compared with the contralateral limb or the control or an analysis of intrinsic factor in the ACLR group. And the outcome was the studies reporting kinematic, kinetic, and muscle activation data, and study type was observational studies. For exclusion criteria, they excluded any study focusing on other tasks such as high-speed running, so it was really not much sprinting or cutting. It was more so just lower intensity running that they looked at.
Perfect. Now, was it more of just like a steady jog that they were doing?
Yeah, so they actually measured it had to be less than 5 meters per second. Less than 5 meters per second was the running they were doing.
Okay. So I think that's important to note because, running mechanics can alter drastically just in a natural way of going from just a kind of a casual jog to more of a sprinting and then obviously more of your multi-directional activities. But I think it is safe to say if we're demonstrating some impairments at lower intensity, lower complexity tasks such as jogging, they will most likely get amplified when we kind of up the ante and try to go into higher level sprinting or longer duration or complexity tasks. Now, what did they actually find within this test?
Yeah, so they looked at 4 different things in this test. So one, they looked at the ground reaction force, and they found there was no difference in peak vertical ground reaction force and ACL reconstruction. They also found that there was no difference in peak and average vertical loading rate between the involved limb and the contralateral limb at long term. For kinematic, they found a knee flexion angle at impact peak during running was reduced at midterm, so that was about 7 months. And there was no difference in long term, so up to about 62 months. They found that peak knee flexion angles during running were reduced in individuals short term and long term post ACL reconstruction. And they also found that knee flexion excursion during running was reduced for the involved limb versus the contralateral limb at midterm and long term. And then for kinetic, they found peak kinetic force was reduced for the involved limb versus the contralateral limb, more so short term than long term. Lastly, they looked at, as kind of like a secondary endpoint, they also looked at some intrinsic factors, and they found knee strength asymmetries rather than surgical technique related to running mechanics post-op.
I'm glad you hit that last point, because that's a conversation that individuals routinely have with me is, hey, should I get a quad tendon graft or a patellar tendon graft or a hamstring graft or a cadaver graft? And the first response I always get is have the conversation with the orthopedic, and they're going to be more well-versed in regards to your individual scenario as to what they feel is your best option. But what I always relay to them, other than just mindfulness with exercise selection throughout the rehab process and just knowing what activities might be more potentially aggravating to a patellar tendon graft versus a hamstring graft early on or at mid-phase, I don't really see a significant change in long-term outcomes. We tend to get pretty good results, in my opinion, regardless of graft type with the types of individuals we see. And I often relay to them, the individuals who tend to struggle with poor outcomes tend to be more of a result of potentially just poor rehab plan of care or execution of that plan of care. And it looks like you mentioned strength metrics were something that were decreased on the surgical limb, correct, compared to the uninvolved limb?
Yeah.
And I think that's something where that is readily trainable, and it is easy to track, and it is easy to monitor. So, Bami, knowing that and knowing that strength is going to correlate to potentially altered gait mechanics, what are just some easy things that you think we can do as a PT profession, or what are things that you find yourself individually doing to monitor strength throughout the ACL rehab process?
Yeah, it's funny you mentioned that. I think key for this I picked up was that, testing is key. So continuing to go back to some of your strength testing to see are they meeting certain benchmarks. So, you could use your force plates, you could use your tin deck, but there's also other tests that you could use if you don't have access to your force plates or your tin deck. Just like earlier on, you could start with them with some anterior tap downs, see what they're getting for anterior tap downs, continuing to also retest that as the goes by. So, yeah, I think just testing for strength and not just testing after 1 month or after 3 months, but continuing to retest and seeing how they're progressing.
And I think you hit the nail on the head with we need to check something. Yeah. And there's a variety of things that we can check, but we need to be consistently checking and tracking something, one, to make sure that we even have the physical prereqs to go into running and initiate running in the first place, and then have a general idea of what is that running actually going to look like. And if we know that specifically knee extension strength and the ability to generate torque and ability to generate force with the knee extension mechanism is correlated to running performance and running tolerance and overall running quality, that needs to be something that we are tracking early on in an appropriate manner and then continuing to track with that. So, Bami, you had mentioned the use of, we have the tin deck equipment, which is just an isometric testing system that we'll use with the individual. We'll have them seated. We'll position the knee at about 60 degrees of knee extension and then have them do isometric strength testing with that. It is great because it gives us just a very objective measure of isolated knee extension. If somebody does not have that available, what are just some other easy and practical ways that they can measure or monitor knee extension strength post-op ACL?
Yeah, so if you don't have the tin deck, there's other ways you could do that. There's anything that you could easily reproduce, right? So, for example, you could do like a tap down. Maybe you could start off with a 6-inch tap down. So you can look at single limb balance, you can look at quad strength, and just tolerance to kind of loading that quad. You can also look at other metrics too, right? So you can look at certain things as something as easy as a Y balance, right? Seeing how they're loading the quad, doing a Y balance in different directions as well.
Perfect. And you had mentioned 2 different single limb stance or single leg squatting variations. The first one you had mentioned the tap down. For those unfamiliar, an anterior tap down or step down test where the individual is standing on one leg, typically on a 6 or 8 inch block, and they are doing an anterior touchdown. And you can quantify this in a variety of ways. You can set it to a metronome, and you can have them try to keep beat with a metronome until they fatigue out and can no longer keep beat. Or you can have them do as many repetitions as possible within a given time frame, 15 seconds, 30 seconds, 60 seconds, and you can compare limb symmetry indices with that, or you can look up where they stack with regards to normative data. Also, something as simple as a Y balance test or even a star excursion test, and looking at how well do they load the affected versus the unaffected limb. And I would say that the anterior reaching direction is going to be the one that's going to target the quad most specifically. Now, with those, Bami, those are both multi-joint activities. They are isotonic in nature, where we're going through a loading and an unloading phase. What's a simple, just isometric test that they can do that maybe they're just using their body weight and they don't have a tin deck available? What else could they do?
Yeah, so you can also do a wall sit. So for the wall sit, the important part about this one is making sure that you kind of document what angle they're at, whether at 90 or 60, just so you can reproduce it, right? So their tolerance to 90 might be different than 60, so we can go back to redo it. You want to make sure you have the same measurement so the results are correlated with their angle. So wall sit, you can start with double leg wall sit at 90 degrees, and then you can move on to single leg wall sit, documenting the time and kind of the strategy they're using, their foot position, and how they're accomplishing the wall sit.
Perfect. And I like how you had mentioned the angle that they are at and also the stance that they're in. So being in a wall sit position, we're going to have a relatively long lever of force for the knee extension mechanism. We're going to be in a vertical trunk position because we're leaned up against the wall. So that's going to take a lot of their hip hinging and hip strategy out of producing force. And it's going to be another way that we can try to isolate some knee extension demands. It's great from a tolerance standpoint, and it's also great looking at muscular strength and muscular endurance. And there's a variety of ways that you can track and monitor progress. Can they tolerate and handle double limb stance? Can they tolerate and handle single limb stance? To what depth are they able to go down to? Maybe you're only initiating that wall sit at 45 degrees, then progressing it to 60 and 75 and eventually 90 degrees. That increase in depth is going to demonstrate an increase in ability and competency. Also, an increase in duration is going to demonstrate an increase in ability and competency as well. So that is one that, regardless of clinical environment you find yourself in, should be very easy to implement and very easy to utilize early on and throughout the rehab continuum with them. I think other things that we haven't touched on yet, but just monitoring what they're doing with their strength training as well. And whether that's in your clinic or outside of the clinic, but making sure that we are putting them in strength training environments that are biasing one leg. So maybe we're doing some asymmetrical lifts where they are loading one leg so that they cannot compensate. And also just monitoring their progression of single leg activities. So I think of like a rear foot elevated split squat or other single leg or single limb biased activities, and making sure that qualitatively they're performing that in a manner consistent between each limb. And from a performance standpoint, they're able to perform the same set and rep and prescribed intensity and volume with that as well. Now, Bami, we had talked about these are some things that we can measure and monitor throughout their time with us. I like that this study went on and tracked individuals even as far as 5 years out. Now, it's tough to say if you're looking at somebody's gait mechanics 3, 4, 5 years post-op, It's tough to say if they're having deficits, if that is due to residual effects from potentially poor rehab or just missed opportunities in rehab, or maybe they had a great rehab, but that was only 6, 8, 9, 10, 11 months. 4 years may have gone by. There could be a lot of other things that happen with that. So when you're discharging somebody from ACL rehab, what are some points of emphasis that you think would be beneficial for them just so that they can maintain strength and maintain all of those good qualities that they spent the last year working with you on?
Yes, I think even before we get to that point of like discharging them, when you're kind of in those last few months, I think it's really important that we don't skip steps, that we're continuing to do our different vertical and horizontal hop testing. And then really important, getting them into your reactive like agility drills, so seeing how they look cutting and twisting, even seeing how they look on the field. So at that point of discharge, where you're discharging them, telling them that it's still important to continue to load the quads, right? It's still important to continue to get into your running and continue to do other things that you can easily control, right? So, most people, when they get discharged, they feel like, okay, I'm good now. And, they are good for the most part, but we want them to continue to engage in their strength training, maybe get into like a strength coach or get in with a personal trainer so they're keeping up with all the stuff they gained through rehab process.
Absolutely. And I think just expressing to them, like you mentioned, that this is an ongoing thing and it's not one and done and then you're bulletproof for the rest of your athletic or active career or lifespan. It's something where they do need to make some sort of intentional effort, at least from a maintenance standpoint. So I think communicating to them, if there's somebody that's just going to continue on with the home program, finding just a short list of activities they can do on a somewhat regular basis, whether it's weekly or biweekly, or maybe we're just giving them monthly or quarterly checkpoints that they can do to make sure that they're not regressing or losing some of these qualities that they maintained. Or it could be, like you mentioned, transitioning the communication over to, if they're a college athlete, to their strength and conditioning staff. Or maybe they're an adult that goes to the gym and works with a personal trainer or a strength coach. Whoever's going to be their point of contact moving forward, just transitioning that from kind of rehab mode to strength training or maintenance mode, letting them know where they're at currently, where they left off, and kind of what the game plan is moving forward. So that way they're not just kind of left in the dark there. Now, Bami, outside of just the strength metrics that we talked about, was there anything else from the study that you think is beneficial to note, either from a quantitative or qualitative standpoint with the running mechanics, or just things that can influence running mechanics?
Yeah, so also something I was thinking about too is just their apprehension to load the quads early on. And then when we think about when we first start to introduce gait patterns in the first month, right? At first, you just want them walking because you want them to see how it feels to be back on their feet. So you're probably not going to be as specific. But there's a point in time in rehab where we go from get them on their feet, we want the gait to be a bit more specific, right? I think sometimes you might think, like, if the gait doesn't look good enough, they might just grow out of it, or they might just do better next month. But there are certain checkpoints that we have to keep looking at, so because we can't just chalk it up that they're just going to grow out of it. So I think just starting off maybe more so broad, but then getting more specific with their gait patterns and how they're walking. I think the ACL course that we have does a pretty good job of kind of laying that down the first month, that you want them to get that quad recruitment, right? And then you want to normalize the gait pattern before you even get out of that first month.
I think that's a very good point to mention, that at different points of the rehab process, you're going to have different intentions. And sometimes you're introducing a new task or a new skill or a new activity, and you just want them to be able to complete the task. And you're not really nitpicking how it's getting done. You just want them to be able to feel comfortable and confident doing it. And you're almost like breaking into this next phase or this new barrier. And you want them doing it safely, but it doesn't necessarily have to be perfect. But at some point, we do start caring about how they're moving. And I think that's where communicating to patients and really recognizing yourself where they are at within the rehab continuum, the different phases of rehab. Is this something where we just want to complete the task, or is this something where we want to perfect the task? And I think a lot of that comes down to, why are we doing it in the first place? Is this because we are acquiring a skill that is going to be relevant to performance and safety of performance-related tasks in the future? That's going to be something that we're ultimately going to need to optimize. Or is this something where we are doing a new movement, but it's the first time we're doing it, and we're just letting them explore that movement, get comfortable with it, kind of lay the foundation, and then we'll build on that in the future. So, Bami, thank you for being on with us today. Appreciate the information. As always, I like the fact that you were doing the dirty work for all of us, reading the articles, letting us know what's relevant within it. And I look forward to having you back on next month when the theme of the residency is the shoulder. And we will see what you have for us that month. So thank you, Bami.
All right. Thanks, Zach.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.